I want to welcome everyone to a very important event. A number of us have been working for 5 or 6 years now to try to bring Dr. Paul Farmer to address this community. We're just delighted that he's here. I'll leave the introductions to Dr. Kristen Page, who's professor of biology here at Wheaton College, but we're honored to have Dr. Farmer with us and have a lot to learn. I just want to say welcome to you on behalf of the community of Wheaton College. I'm sure we have visitors from the community. This event tonight is co-sponsored by the Office of Global and Experiential Learning, by the Human Needs and Global Resources Program, by the Center for Applied Christian Ethics, and by my office. And we're just delighted to be able to welcome Dr. Farmer here. We look forward to a wonderful evening of learning about how to better care for human needs around the globe, particularly his models of medical care delivery. Would you join me for a brief word of prayer? Holy Father, we thank you that you yourself are the model of love. We thank you that in you we see one who has poured out his own life for those that he loves. And Lord, you are the ultimate model of sacrificial love in our lives. We have so much to learn of how to care for the human need that crowds around us all around the globe. Thank you for pioneers like Dr. Farmer, who explored new ways to extend care medically and in other ways to those who are in greatest needs around the globe. And so we pray, Father, that we would have hearts and minds that are open this night to learn and to be more effective in serving your children around the globe. In Christ's name we pray. Amen. Dr. Page.
Well, this is certainly an exciting night, right? This is very exciting, and it's my privilege to be able to introduce you Dr. Paul Farmer. Medical anthropologist and physician Paul Farmer is a founding director of Partners in Health, an international nonprofit organization that provides direct healthcare services and has undertaken research and advocacy activities on behalf of those who are sick and living in poverty. Dr. Farmer and his colleagues in the U.S. and in Haiti, Peru, Russia, Rwanda, Lesotho, and Malawi have all pioneered novel community-based treatment strategies that demonstrate the delivery of high-quality health care in resource-poor settings. Dr. Farmer is a recipient of numerous honors, including the Margaret Mead Award from the American Anthropological Association, the Outstanding International Physician Nathan Davis Award from the American Medical Association, a John D. and Catherine T. MacArthur Foundation Fellowship, and with his PIH colleagues, the Hilton Humanitarian Prize. Please join me in welcoming Dr. Paul Farmer.
Thank you. This is a rowdier bunch than I thought. I don't hear people yelping for me at Harvard when I give a talk, which I'm rather resentful about that now. Although for a Christian college, I was just in the men's room and heard people talking about a mortal enemy. So totally busted by the speaker. I'm going to talk a little bit about our work, and I have to say I apologize if it's been a while since I was invited to come here. I actually thought you were that you were interested in inviting me. I should have known that Kristen was behind this. I share your general approbation of for Dr. Page. Was because of a book that I had just written with a theologian. And I'm just going to say a couple words about him. Oh yes, let's point it up there. And this is Gustavo Gutierrez, Father Gustavo Gutierrez, who I was lucky enough to meet about 20 years ago when I went to Peru. But before that, when I was your age, I was already thinking I'm going to be, again, I'm speaking largely to the undergraduates. I know there are faculty and graduate students here as well. But I knew somehow that I wanted to be involved in healthcare. For poor people. I understood that as well, and had aspirations even in college to go to either West Africa or Plan B was Haiti. And I was reading a lot about what was going on at the time. This is 30-something years ago. To take away you'll see that this was in the middle of a time of great turmoil in Central America, in Latin America, but particularly in Central America. Civil war, and some of you are working in these places now and know a little bit about this history. But as a young American in Durham, North Carolina, couldn't understand what was going on. And so I did what you're supposed to do when you're a student, which is read and talk to people. And when I applied for a Fulbright grant to go to Senegal, there were a couple of signs that my life would not work out exactly the way I thought it would. For example, it did not occur to me that I would not get the Fulbright grant or even an interview. I also wrote a letter, a really well-composed letter in French, to an eminent professor of medicine with whom I wished to work in Senegal. And got an answer about 3 months later saying, well, we're sorry to inform you that that professor died 2 years ago. So that I hope would not happen with you guys. You'd actually do your homework ahead of time. I mean, it'd be one thing if he'd passed away a few weeks prior to me writing the letter, but 2 years. In any case, I'm telling you these two stories, or the same story, because there's a lot of ways to get involved in social justice work. Social justice work, including work around health disparities, which I'll talk about, can happen any place. There's a lot of work to do in cities and rural areas in this country. So when I talk about global health equity, and I'll try to define it a little bit more using a case, I don't mean international health, which is what 30 years ago when I was a student, people were talking about, doing international health. But as I said, it's better to think about global health equity. I'll make a case for that tonight. But I wanted to start, instead of trying to give a talk about theology, which I'm not qualified to do, I will just say that when I went to Haiti in 1983, 23 years old, never having lived out of the United States except for a year in France, where I cultivated the ability to write those really good letters in French, not based on good research, I was very overwhelmed. It was a very difficult time. And that's when I started reading the work of Gustavo Gutierrez. So imagine how fortunate I felt 10 years later, having read a lot of his work in medical school and graduate school as well, to meet him in Lima, which is his home city. And we became friends, and then just last year we wrote a book together. It's sort of a conversation. And that describes, if any of you want to read about global health equity from the point of view of a theologian and a physician who's not a theologian, I can refer you to that book. But that's how I wanted to make my connection to theology, to thinking hard about problems like why does poverty exist in the world? Not just why, but how is it structured, and how is it structured over time? How does it change? Why are some people living in such profound poverty while others are spared from all risk? Why, in addition to the kind of violence that I was reading about in Central America and even Haiti, why is there also a kind of structural violence where some people have to get up every day of their lives knowing that they're at risk of something terrible? An accident, aggression, oppression of one sort or the other, dying of a treatable or preventable illness. That's really been something that I've been struggling with my whole life. And I'm lucky enough to work with a lot of people at Partners in Health, and even at Harvard Medical School and across the world, who are struggling with the same questions. How can we make a difference in lessening that kind of violence, not just the violence that I think everybody should deplore, aggression and war, but the violence that poor people have to face, or people rendered vulnerable by other social forces. Racism, for example, or gender disparity. But when you talk about these big questions without grounding them in an experience, it becomes a very abstract discussion, or one that seems beside the point. And I just want to talk a little bit about the specifics. By the way, I don't really know what this is dangling on me, but I assume the NSA will. Now, so this was 1983. I ended up, I'm trying to tell this story more, so that, especially when I'm around undergraduates, the story of not getting things the way you want, story of not getting an interview for a Fulbright, much less the scholarship. Because sometimes people say, well, it seems like things have gone really well for you, but that's not really how it plays out. In Haiti, for example, it did occur to me that I wouldn't be needed at a missionary hospital in central Haiti. So I was, just for the sake of argument, I was going to say, it didn't occur to me that they wouldn't need the help of an enthusiastic young 23-year-old who didn't have any medical training, any training at all, in fact. So when I went to this hospital, not just one, but a couple of them, all I wanted to do was volunteer. And I'm trying to think of a good young person term. Scorn sounds too Shakespearean. What is the thing you guys say when you get dumped by a girl or something? Denied? Whatever. I don't know. But they were not interested in having me work with them. It took me a long time to find some place to work as a volunteer in Haiti. Now, I know a number of you in this room are struggling with questions like that from here in Wheaton, right? How can you be involved in work? Sometimes you'll say, like this. But it's not straightforward how to do it. And doing it in a way that's constructive for everyone involved, that engages you long-term in this sort of work, we have to struggle for that. I did in Haiti, and eventually ended up with a group of people, Haitians, in a town called Mirebalais. And I want to say that 30 years later, I'm still working with those same people and in that same town. I'll prove it to you in a minute in the course of this lecture. But the point I'm making here is not to show how steadfast I've been and how focused on the same problems, but to say it's not easy to get involved in meaningful work, but it's worth it to struggle and try. And that doesn't mean work that takes a place far away. Again, there's all sorts of problems close to us as well. But it's not only worth it, it's been a great joy to me to be involved in this work. Now, the big questions of poverty and their specifics. This is one of the places I first went in that year in 1983, before I went to medical school, was a place that was a squatter settlement about it took a long time to get from this town where I was staying, Mirebalais, to Conge, but it wasn't very far, just a few kilometers. There just wasn't a road. Now, why were people living in a squatter settlement? First of all, how many of you have been to a squatter settlement? It's hard to do this with hundreds of people, but a lot of people have, right? And most of them are probably in cities, right? What is a squatter settlement? Squatters from what? And in this particular case, they weren't, as in Lima or Nairobi or Delhi or many of the cities you've been to, these people were not fleeing rural poverty and ending up on some hill. They were fleeing a hydroelectric dam, a development project that had flooded the valley where they worked. Now that was an object lesson for me too. Many years later, I was asked many times after having written a couple of books about this place and about this dam. A couple of people said, well, what have you got against dams? And I said, what are you talking about? I don't have anything against dams. Then I realized, they're talking about the Peleg Dam. It's true that I did have something against that dam, and that was simply that it displaced people without a plan for them to make a living. But nothing against dams per se. And I'm sure dams always do that, but you can imagine, right, when you flood a valley for both to manage agriculture or to generate electricity, which has been going on, as you know, for quite a long time, you can have some strategy whereby you wouldn't injure the most vulnerable people, the rural poor or the urban poor displaced. And so that was another one of those lessons that I still think about. Because it's easy to say, well, people in charge of development programs are thoughtless, or they have hubris, or you could make a long list. But really, when you start meeting those people working in development institutions, you see, well, a lot of them are very well-intentioned. They want to reduce poverty or want to bring electricity to poor people. And that is why I'm still thinking a lot about, well, Haiti's still struggling without electricity. What should be done? What went wrong in the past? Why did this project not work, either to promote much in the way of sustainable agriculture downstream or to generate power for those who were living in the darkness? And there's still legitimate questions 30 years later for me without easy answers. That was what I wanted to say, not just speaking to you as a physician or a professor at Harvard, but rather as someone who got involved in this kind of work as someone in their early 20s because of my experience as a college student. In fact, even the medicine and anthropology, which I later studied in graduate school, I started because I took a class at Duke called medical anthropology. So be open to not having everything work out, but also be open to what you can learn from each other, of course, and from experiences that might not happen here at Wheaton, but also those that happen in a classroom. That's why you're here. Now back to the medical work. I'll talk a little bit about why I think global health equity is a useful term. And this is a patient who, same person, of course, a before and after patient, before and after picture, someone who I got to know well over the years and still know well. But the reason I use this is because it's an example of something that you see all the time, any place you work as a nurse or a doctor or a provider. You can see it in a school, and as a school teacher. That is, some people are doing poorly and some people are doing well. And as medicine advances and public health as well, what does that mean to say medicine advances? That means we have new tools to prevent illness, like a vaccine, or to diagnose it, or to treat it. In fact, it's not or, but and that's what's happening in the 25 years since I graduated from medical school. There's been a rapid advance in medicine, but not in our healthcare delivery system. That's one of the points I'll make tonight. So, in other words, we have a lot more and better ways of diagnosing and even preventing illness, and certainly of treating it, than we did just 25 years ago, but we haven't worked out the delivery system. And the argument I'll make here is that we can learn a lot from places like Rwanda and Haiti, the two countries I'll focus on, about how to better deliver care. But this patient, so what's wrong with this guy? What's ailing him? If I told you had 3 problems, 3 ailments, I'm sure you could figure out that one of them is AIDS, and one of them is tuberculosis, which is the most common. Some people in this room are going to know this is the most common opportunistic infection that kills people with AIDS, in fact, in all the places of the world practically that I work. And then he's got inanition or starvation, and that could be due largely to the 2 illnesses that he has, or it could be due, of course, to those illnesses plus not having enough to eat. Now, he had all of those problems, but that's the same guy just a few months later, not in the hospital, but in the clinic where I was seeing patients at the time. Now, why am I using this as an example of global health equity? And it's just, I want to link it to the date of 1998. I graduated from medical school in 1990. That must make me seem really old to you guys, doesn't it? And went back to Haiti for another year and then started training in internal medicine in 1991 and then infectious disease. And during those years that I became a doctor, really responsible for people. And I heard a trainee of mine, a young woman from Philadelphia who's an internist, say, she actually wrote it down. So you don't really learn medicine, you don't learn how to practice medicine in medical school, you learn it during residency. And it's true, because you're responsible, you work with a team of nurses and senior physicians, et cetera, but you're in charge of, or you're responsible and you feel it. And during those years, I can tell you in the United States, at the Harvard teaching hospitals where I trained, the leading killer of young adults in American cities was AIDS also. And in Boston, all over the country. And it's still, among African American women, for example, living in poverty, it still ranks as a leading killer of young adults in the United States. But it was a big problem because people were getting admitted to the hospitals, but they didn't go home unless they went home for palliative care. I mean, they were sick and we didn't have treatment. And those, again, this was also going on in Haiti, but even in greater numbers. Because one of the reasons was because of the tuberculosis problem. Now, tuberculosis epidemics happened all over the United States as well. And some of you will be studying that, related to lots of problems, not just HIV, which was always mentioned on the list, but also an epidemic of incarceration that started in the late 70s, early 80s, and still goes on to this day. So complex problems. But speaking as a young doctor, I remember how amazing it was to see in the course of those first few years of my training, the development of treatment for AIDS. Because the hospitals cleared out. People got therapy and they went home. And that was pretty powerful to think that I would be going for years between Harvard and Haiti, and it took about 5 hours to get there. There were direct flights from Boston back then, between Boston and Port-au-Prince. And 5 hours later, you could be in a place where AIDS had gone into a sharp decline in terms of death from AIDS, and in another place just around the corner where it hadn't. So global health equity. Now, this was in 1998. I told you that I didn't give you the exact dates. By 1996, it was clear to anybody who was involved in clinical medicine and infectious disease, it was clear that we now had a treatment for this disease. And it was clear that it was having an enormous impact in the United States and Europe, and not having an impact where the burden of disease was greatest, which was Africa. And so then you started thinking, why not? And of course, just like thinking about the dam years before, why did this project not have the intended consequences only? The why not, and I would encourage you to take this seriously. Why is the world this way, and why can't it be better, are important questions to grapple with. And I don't think it matters if you're a physician or an engineer, a school teacher, or a researcher. And this problem became, for our Haitian coworkers, and for me and for many of us, the answer was, why not? We can figure that out, but how can we change it? How can we make it different? In other words, how can we think of this man on the same globe as the patients we were seeing in Boston? And how can we promote his health in a manner that reflects our desire for equity? That's why we talk about global health equity. Now, for this guy, the answer to his prayers, was met, right? Because he got this therapy through Partners in Health and its sister organization in Haiti. But that was only 100 patients in 1998, a small group just in Haiti. I would bet you that if you looked hard, and I have, I'm actually with one of my former students who met me here tonight. We've all looked hard. If you look hard to another rural area or even an urban area in Africa, you would be hard-pressed to find a single project that was treating poor people with AIDS with the proper therapy. In fact, even a few years later, 10 years ago, you would have had a hard time finding many except, again, pilot projects like this one. But then everything changed. And then we asked the question, why and how did it change? Well, you needed a couple of things. I mentioned already, one very scientific way of putting it is you need staff and stuff. You need people, and you need diagnostics and treatments, and for someone like him, you need food, right? And he's got 2 diseases, so it's not just 1 or 2. It's not like a vaccination. But how do you get staff and stuff? And of course, there are lots of other questions. Who should be the staff? Do you really need an infectious disease doctor like me to take care of millions of people with AIDS? If, by the way, people like me, infectious disease doctors, said, oh, you need to be an infectious disease doctor to treat AIDS, let me tell you, there would probably be about 10 million people more dead than there are now, because that was not true. You did not need an infectious disease doctor to treat millions of people living in poverty and AIDS. You did need staff and stuff, including community health workers, nurses, and of course, people with that training in treating infectious diseases were useful, but that's not what drove this forward. Those weren't the staff and stuff that drove this forward. Here's what happened, and I want to, in Haiti, we worked on how to deliver and with what staff, the stuff that we had, right? And the stuff can be preventive, right? Sometimes it's a vaccination, sometimes it's a message, about how to prevent a problem. But you still need a delivery system. This is what I've said is not very strong in the United States. And the reason it's not strong is that it lacks a certain part of this triad that I'll describe. On the one hand, our community health workers, that's the majority of the staff. In fact, Partners in Health, which has a large staff globally, about 13,000 people, I think about 75% of the staff are community health workers. And most of them have never had a job before. And we use the term accompaniment, which we stole from where? From liberation theology and people like Gustavo Gutierrez. The term accompaniment, because we said when you have a chronic disease that's not curable, or even a chronic, like if you have an ailment, like you just saw a patient or heard about a patient and saw another one of them, a girl who fell out of an avocado tree, 30 feet, and in Haiti. And she needed lots of accompaniment in the sense of she needed a lot of surgeries, but also she had traumatic brain injury and she couldn't speak at all. To go from that just a couple of months ago to walk out of that hospital requires accompaniment from medical specialists, but also people to help her get home and help her at home. So that's why community-based care is not just about problems like an illness that you don't need to go to the hospital for. It's also important for other afflictions, more dramatic. And then health clinics, that's where the majority of care can take place. And hospitals, when you ended up like my patient and now my friend, the guy whose picture I showed you, really sick, couldn't walk. In fact, we used the term CIOS, carried in on a stretcher. You need a hospital. Now, what do you think is before I just answer, in the United States, which of those 3 pieces are we missing? Yeah, we're missing the community health workers. Actually, I'm very relieved to hear that being the main murmur coming out of the audience, because it's important that we understand that in our country, because we're putting so much of our resources into healthcare, but we're not getting the return we want. And one of the biggest lesions is we don't have community health workers. In Haiti, what do you think it is? In rural Haiti or rural Rwanda? Hospitals, clinics, and community health workers, because nobody wanted to pay them. So we had people who wanted to do the work, but I think we have people who want to do that work in the United States too. And in Russia, for example, it wasn't hospitals so much as community health workers. You go place by place, and you'll see that you can use this little triad. I say to my medical students, now this is really complicated if you want to take notes. But it's not very complicated, but it's very helpful. Everywhere you go. And again, the example I've been giving more often is trauma. Trauma is road trauma is the leading killer of young adults, teenagers too, in a lot of the places in the developing world. And I think back more these days than when I was younger about how I was stupid enough to not listen to my mother and walk right in front of a car. You'd think if I got into Harvard Medical School that I would know to look both ways before I crossed the street in Cambridge, but no. And when something like that happens, and this happens all over the world, the leading cause of plunging from poverty into destitution in the world, in almost every country, is catastrophic illness. And that can happen to any family, and I'm sure it's happened to members of your family. But if you had like me, had an orthopedic emergency, needed surgery, couldn't walk for a while, needed rehab, etc. If you had insurance, then you might be okay. I've recovered in no time. But a lot of people, that's either they die or they have permanent disability. So this system, this community health workers, clinics, and hospitals, is the minimum that we need as a species if we want to use the tools that come from global health equity, use the tools and fruits of science. And there are lots of examples. You can think about treating diabetes. You can think about treating chronic hepatitis C, which I'm obsessed with because we now can cure it. And 170 million people in the world are living with chronic hepatitis C. Now we just finally got cures. Now, how do we get AIDS care out to so many people? Here's a story that I think is great to know and kind of uplifting. Well, if you need staff and stuff, that basically means you need money. And if you need money in order to take care of people and they're poor, you can guess how well out-of-pocket expenditures work to roll out care for an illness that afflicts predominantly poor people. I mean, anybody who argues that that's a good strategy to bring a complex therapy to people living in profound poverty is not being honest with you. That's not the way to finance it. Self-finance it, out-of-pocket fees, user fees, et cetera, never work. And in fact, it didn't. That's why there wasn't much in the way between the discovery of effective therapy for HIV. And again, I'm using HIV as an example. What about the discovery that insulin could save the life of a diabetic, or that an antibiotic like penicillin could save the life of a young person with acute pneumococcal pneumonia? So in general terms, when there's a new development that can save lives, HPV vaccine to prevent cervical cancer. When there's a new development, you need to have a plan for delivery. And if it's a problem that afflicts poor people, which is my primary concern, and I hope many of yours, you need an aggressive effort to move resources. And that's what you should, I think, as Americans, you can be proud that I won't go through all the what these initials mean, but were you, I'd be pretty proud that the U.S., United American people, and the President's Emergency Plan for AIDS Relief is the largest funder of not only care, treatment of people living with HIV, but also prevention and diagnosis. And they're linked together. Now, how did this happen? We have another big debt to AIDS activists from all over the world, but especially, I think, from the United States and parts of heavily affected Africa, who push forward this equity message. They didn't push forward the message that this was an economically prudent thing to do, or that would be required to prevent epidemics of tuberculosis, or that it was sustainable. They did that as well. But what they really argued was, this is the right thing to do. And again, don't let people take away from you those basic human rights frameworks. They're ours to keep. You say one person is just as important as another, then how does that play itself out? Now, you could say, well, it's easy to say that, but has there ever been an example of any really reaching millions of people living in dire poverty and facing a problem like this? And the answer to that is probably no. There's never been an example before, but this is an example. This is the largest public health endeavor, transnational. Even in human history, larger than the eradication of smallpox in terms of investment, larger than, the attack on mosquito-transmitted illness around the building of the Panama Canal. This is the big one. And it actually provides a treatment that's required for life, since this particular disease is not curable, not yet. So this is something everybody should know about. Now, what happened afterwards? I want to give one example, and I'm mindful of the time, and I don't want to get involved in too much detail, as if this were a public health class, but there is a public health class right here, so you should be liking this. And this is fairly recently reported data. This is from a paper just published a couple months ago, and it's obviously the data of the Rwandan, the people who worked hard on this. I've been lucky enough over the last 10 years to be working there. But this shouldn't surprise you, although it's very dramatic. That is, if we do have a treatment, which I told you, and I think you believe me, we did, was developed in the mid-90s. If we have a treatment, and then we scale it up, to use public health jargon, which I assume you're adopting even as we sit here, and you scale it up, then what would you expect to happen to deaths from that illness? You'd expect them to drop, right? So this is not surprising. This is what you want to happen. Again, choose another problem. Choose epilepsy in a poor country. Choose childhood epilepsy. Choose even major mental illness causes great, not just suffering, but death. So my argument would be this is an example of the way we should be thinking for all sorts of health problems. Now, this was scaled up through the public sector, meaning the public health system, but groups like Partners in Health and many others participated. Actually, a couple of faculty members who are here tonight, like Dr. Kang, have been to Rwanda and been involved in efforts to bring this to scale. Now, what does that mean, to scale? That means that everyone, or most everyone who needs it, gets it. Now, did Rwanda, which 20 years ago this Easter was lay in ruins, do you think they succeeded in doing it? 20 years ago, this was the country most likely to be dismissed as a failed state, a lost cause, a hopeless enterprise, over 1 million people murdered in just 1 year, the preceding year, and probably the poorest country on the face of the earth, with the highest infant mortality, highest juvenile mortality, kids. A lot of people have said there's just no way that this place is going to recover. But they did and are. I'm not saying you recover in the sense of erasing that kind of horror. It's not. We don't even know as a species how that is done. But we do know a lot about how to scale up care for diseases, including this one. And how well did they do? Some people say, well, why did Rwanda enroll so many people? Because 120,000 people, I'm going to argue in a minute, is pretty much universal access. How did they do it? Did they have a lot of money that people gave after the genocide in 1994 because they felt bad about having missed it? Plausible hypothesis, but false. When compared to surrounding countries, including Tanzania, Kenya, the neighborhood that in East Africa, Rwanda receives less per capita than other countries in aid, including the generous aid, as I said, that came from the Global Fund to fight AIDS, tuberculosis, and malaria, and the U.S. program, which is called PEPFAR. So it wasn't that they got more aid. How about that they spent a lot more than other countries on health care? Well, as a fraction of their national budgets, they did spend more, but it was a tiny amount because this is a very poor country. And here's the numbers that this is, I think this is, again, something really worth knowing whether you're in public health or not. So on the most afflicted continent, Rwanda beat every other country to universal access, with the possible exception, which I doubt, of vastly wealthier Botswana, with a GDP many times larger than Rwanda's. And you can see that there is not a correlation between how much money they had and how well they did at scaling up. there was a correlation instead of between the success in reaching universal access and a plan for global health equity. And what did that mean in Rwanda? It meant that the public sector was committed to rolling this out, and especially at reaching the poor and vulnerable in rural areas, women, people living with poverty, and an illness like this. And in fact, they linked this to the fight for gender equity as well. If you look back at the plans written in 2004, when there was basically nobody on therapy there, and again, I'm not sure when faculty here had been there, but some of you probably remember when there really was nobody on therapy. The numbers suggest it. 2004, they wrote all this into their AIDS plan. We will attack poverty and build health systems as we're using this generous aid that we don't have for other problems, like major mental illness, diabetes, epilepsy, cancer. And that's just what they did. Now, this is what happened. I want to compare Haiti and Rwanda. Now, Haiti did pretty well, too. Some of you, how many of you have been to Haiti? A lot of you. After people think that, things are pretty dire in Haiti, and they are, but it's not really possible to argue that there hasn't been improvement around, say, child survival. That's happened in Haiti as it has elsewhere in the poor world. People talk about the childhood survival revolution, which is a great thing, right? And I remember 30 years ago when I was venturing into this, world and work, people used to say, well, there's going to be a population explosion and the whole world's going to fall apart if we save these kids' lives. First time I heard that, I couldn't believe it. I heard that in a medical setting. Well, you save kids in the third world, their population's going to explode and then poverty's going to increase. Well, the population did explode, but poverty went down. So also be very careful as students when you hear these claims about how to link the right thing to do, save a child, prevent an illness, to the problems that we're seeing in the world that your generation is inheriting. But they're not what we predicted 30 years ago. So in Haiti, too, there was massive decline in AIDS-related deaths because there was, again, ample support, or not ample, but generous support for programs like that. That's how we scaled up our program from the Dominican border to the coast at the other side of Haiti. And some of you have probably visited our work. You can see that there's decline in child. Look at this is both AIDS mortality, case fatality rates for HIV disease, to use the lingo of medicine, public health, but also child mortality. Because if AIDS is the leading killer of kids, or a leading killer of kids, if you treat it, of course, all child mortality, you'll see it drop, which is what happened. Now, there's a big spike in 2010, and I don't have to tell you what that's from because you all know. But that's how significant, that's what the earthquake did in Haiti. I will say that it did not reverse the gains made with HIV, with AIDS. It didn't. And even a big cholera epidemic that's still going on did not reverse the gains made with AIDS. What that revealed, again, was the need for that model, like I said, that goes from a community all the way to a hospital. Because it reveals, of course, shoddy construction, the lack of awareness, the lack of emergency planning, all the things that you read about after the earthquake. But it really does reveal that you need, in order to save lives, you need the ability to provide hospital care. And that was painfully lacking in the days and weeks after the earthquake, as many of you know. Now, why did the Rwandan horror show, meaning the spike in mortality in 1995 and 94, where Rwanda became a killing field, why did the rate of improvement increase more quickly in Rwanda than in the United States, for example? If you look at the reduction of mortality due to AIDS, that drop in Rwanda is steeper than anywhere else in the world, ever. In fact, it's not just HIV mortality. If you look at, I'm going to go back to this. If you look at historically famous reductions in child mortality from across the world, you see that Rwanda has the sharpest, steepest declines ever documented anywhere at any time, which I think is pretty remarkable. I mean, again, remember, 19 years ago, the whole world was saying that this place will never recover. It's going to be a basket case. How many of you have ever been to Rwanda? They're not too many, but trust me. Well, you shouldn't trust me. Professors aren't supposed to say that. Study yourself. You'll see that that claims that they would not recover are not true. Now, I'm going to make an argument and then go back to Haiti and open this up for discussion. The argument that we've made is that the reason that the rates of reduction are so steep in Rwanda is because it built up the public health system. And that means that the Rwandans rebuilt their own institutions with these resources, right? They used our aid, moved it through their institutions, and rebuilt or built capacity. And that ends up being called, in, again, new jargon, some of you will be interested in this, we can talk about it later, health system strengthening. That's the approach they took to strengthen their health system. And it worked. Now, here's an example of how it works on a clinical level. If you compare Rwanda now to the United States, I said the rate of reduction was faster and steeper in Rwanda than the United States. Why? The medicines were the same, the virus is the same. In fact, it was worse in Rwanda because of the tuberculosis that I mentioned and the food insecurity. So you would expect outcomes to be much better in the United States than in Rwanda, but they're not. And here's why. Because Rwanda, with a system that includes community health workers, can expect patients with chronic disease to stay on their treatment. You guys are too young, but when you get to be my age and you start having chronic ailments, like high blood pressure, and you have to take medicines every day, let me tell you, to use really scholarly language, it's a drag. Because it's hard to remember. And then what about when you have to take 2 or 3 medications? In some practices, elderly patients, and sometimes younger patients, are on 7, 8, 9 different medications at a time. How can anybody do that? I mean, I know I can't. I need an accompagnateur full time. But so it is in Rwanda and Haiti and Malawi and Lesotho and the United States too. We need community health workers. And that's one of the reasons that if you compare an AIDS patient in the United States, this is a study from the US government actually, you follow when they get diagnosed, when they're referred for therapy, which here in this slide is called HART, which means highly active retroviral therapy. How many of them have the outcome you want initially, which is called viral suppression? You check the blood, you can't see the virus, it's suppressed. But then, if you go back and restudy them later or look later, only a quarter are still suppressed. And that's not because of a failure of treatment, meaning the medicine doesn't work anymore, it's because of delivery failure. Usually they're not taking the medications. And again, it's 3 times higher. And again, you know, these will vary over time, but the outcomes are better in Rwanda and the rate of reduction in mortality is steeper in Rwanda because there's a better healthcare system. Now, that's why publishing some of this stuff this last year has generated interest in the United States and elsewhere, where chronic disease, right? Diabetes is a chronic disease, serious complications of hypertension, go right down the list. When you have a big chronic disease problem, as the United States does, there are things that we could learn from Rwanda. It's not just the United States. Places where that historic reduction of child mortality and the death of young people is gone. It's very rare. Most of you have never known a child who died. Just the numbers are on my side when I say that, because not that many children die in the affluent world. And when that happens very rapidly in places like Rwanda, of course, they see all of the chronic disease burdens and non-communicable disease burdens that we didn't see because it was masked by such early death from vaccine-preventable illnesses, HIV, tuberculosis, malaria. First year I practiced as a doctor in Rwanda, 2005. It was a nightmare because of malaria, just a nightmare. We had people coming in, dying right there, staff dying. That doesn't happen very much anymore. It's a massive reduction in malaria mortality. And when that happens, again, and life expectancy goes up, you see the kind of problems that you see here in the United States. So there's learning that can go both ways. That's global health equity. Now, I want to close with thinking about Haiti a little bit because so many of you have been to Haiti, and I know there are a number of you who want to talk about Haiti, and I said I would. I don't really like talking about the earthquake that much. I don't think you can blame me. And there was a while where I just wouldn't do it, wouldn't refuse to do it. But there are a lot of lessons that we need to learn, not just for Haiti, but for elsewhere. And one of them I mentioned already is that once something like this happened, I use the metaphor of once you walk in front of a car, what you need is not someone to scold you for not looking both ways. And no one did scold me, by the way, when I was lying in the street with, a broken leg. No one said, "You should have looked both ways." I would have resented it, to be honest. But you have to have a little humor in some of these, not the dark moment. Actually, someone said to me, "Boy, that must have been quite an experience, not being able to walk for months." And I thought, no, it really was pretty banal, actually. I knew that I would get good medical care, and I did. I knew I would get the surgery I needed. I knew that I would get rehab. I knew that I would have someone helping me to fill my prescriptions. I knew that I would get back to medical school. And all those things came to pass. But the kind of insecurity people living in poverty face is nothing like that at all. The kind of insecurity that you face in a hurricane or an earthquake, to say nothing of war, it's completely different. Now, can we prepare for that? Of course we can. Can we help others prepare for that? Of course we can. What's the best way to do that? Is it to build more and more NGOs? A number of you work at NGOs. I do. But do you think the NGOs or small faith-based organizations that many of us, you, support, how are they at managing massive trauma? After the Boston Marathon bombings, there's a reason that not a single person who made it to a hospital died. We didn't send them to, tiny little missionary clinics, the people injured in the Boston Marathon. They went to the teaching hospitals, like the Brigham and Women's Hospital, the Mass General, the giant teaching hospitals where I trained, where there are redundant system after system to care for critically injured people. That's why they didn't die. They had surgeons and anesthesiologists and nurses and labs 24/7, team after team after team. That's why it happened that way. So yes, we may be involved with faith-based organizations and community organizations and NGOs, but they're not the answer to building the capacity to either roll out a massive program like the Rwandan AIDS program, nor to prevent mortality from trauma after an event like the earthquake. And that's one of the lessons that I've found hardest to transmit collegially, because people take umbrage when you say that what we're doing is not adding up to more than the sum of our parts. And that's also self-critique, right? Because I work with an NGO, and we found ourselves, yes, perhaps better able than most to provide care for people who needed trauma surgery, but still nothing like what we wanted to be able to do. And so what should be done? What did we do? Well, first of all, I know that a lot of people in this room contributed to Partners in Health after the earthquake, so here's the chance to say thank you in person. But this is what we decided to do as one of our major programs. We had many programs after the earthquake, including mental health programs, rehab programs, et cetera. But I'd like to give you an update on the largest one. First of all, the building of infrastructure. And remember I said staff and stuff. Well, this is the main nursing school in Haiti, 3 days after the earthquake. Now, Also, the medical school and hospitals mostly collapsed. And actually, you can see in the background the end of the general hospital, which is where a number of us were working. But how do you rebuild from an event like this? You have to retrain professionals, and one hopes train them better. Almost none of the third-year nursing class survived, nor did their teachers. And you have to have the infrastructure. So what we decided to do as our major effort, and again, this was a lot of controversy and not very fun, to have actually the debate, was to build not the community hospital that we'd planned to build in the same town, by the way, of Mirebalais, where I had shown up 30 years ago. That's not why we were working there, because I had been there, but because it was the largest town in central Haiti where we didn't work. And so we said, we want to work, and we'll build a small community hospital. But after the earthquake, instead of ratcheting down our expectations, we said we're going to elevate them and build a modern medical center. And by the way, we'll build it to California earthquake standards, and we'll make sure that it's powered by solar energy. And I remember hearing a lot, and again, a lot of people said, well, it's not going to work. And then there's lots of reasons to think it wouldn't work. Remember, you can take the despair that was felt after the earthquake, or you could say, well, we were already working on solarizing all the hospitals that we worked in Haiti. And on the day of the earthquake, one of my friends, an American who was working on this, was killed in the earthquake. And those kinds of setbacks happen whenever you're working in such fragile settings. They usually don't happen to us, mind you, but they happen to the people who live there and are subjected to that kind of risk. So I think there were some people who thought it wouldn't happen, but it did happen. And this is a picture sent to me just a couple weeks ago, I think, 3 weeks ago. A helicopter approached the hospital. It's done. So, well, now I can say it's done, and that would be perhaps an exaggeration, but it is a functioning teaching hospital. We've launched there in the last 6 months the first training programs for Haitian doctors in rural Haiti, and in surgery, pediatrics, and internal medicine. There's also an enormous ambulatory care program that's linked to the community health workers and the other places we work. I'm just wondering, any of you been there? It's a very beautiful place. Actually, these are outdated pictures. It looks a lot better with patients in it, I must say. Now, is this the answer to Haiti's problems? Of course not. You need a system, as I said, a system that can link energy of all the people who are working in Haiti, and there are lots of NGOs and faith-based organizations, as I mentioned, and mission groups, somehow to link that energy to building a system of Haitian institutions. That's what the Rwandans have been pushing, and that's what the Haitians want too. And so global health equity is not just about taking care of sick people. It's about removing people from the risk of dying prematurely because they live in poverty. And to do that, you need systems. It's not about one physician or nurse or 10 or 100. It's about a system that can deliver on the promise of health equity. And there's no doubt that we have a lot of the technology and understanding of the staff and stuff needed to do that in Rwanda or Haiti or the United States. Now, I'm going to keep my promise and close by saying this is the question I get asked the most. And again, I have to, one of your administrators and faculty members was talking to me earlier. She was talking about the strain it is to hear again and again the same question or the same observations. This is a legitimate question for some things. But in my experience, is it sustainable is very often a question that's meant to say, no, it's not. My daughter could tell you, she said this before, you can tell by the way someone's asking the question what they are sure the answer is, and it's true. Right? Sometimes it's asked with an animus that is meant to say, it's not sustainable. And the way we ask the question, the tone that we use is critical because there's such a difference in between saying, is it sustainable? But is it sustainable? And how do we sustain it? How do we build it and sustain it? And I would say that this has become one of the biggest problems that we face in this work, global health equity work, development economics, is we need to be asking questions about sustainability, but not the question, can we sustain good things for poor people? That's an outrageous thing to keep doing again and again, and stops the discussion about how to sustain things that are good and get rid of things that are not good and not healthy. And that's where a lot of development economics is stuck, and that's where international health got stuck too. Because when the answer to this question is no, then you shut the door on poor people. No, it's not sustainable to provide trauma care when I just told you that trauma care is the leading killer of young adults. Trauma is the leading killer of young adults. Again, I want to see people wearing their safety belts. What are they called? Seat belts, safety belts. I wish I hadn't walked in front of a car. You know, prevention is better than care. Fine. But to say that it's not sustainable to provide a safety net for people living in poverty is the root of a lot of problems that we're seeing as we try to move health equity forward globally. In fact, we hear this question so much that a friend of mine who's the Minister of Health, she's a pediatrician, she's the Minister of Health of Rwanda and one of the architects of a lot of this work. I hope you'll read about her. Her name is Agnes Binagwaho, great lady, Binagwaho. And she is the one who I first saw use this slide. She said, we asked this question about sustainability so much that pretty soon every sentence we use is going to have the word sustainable in it. And by the year 2017, we project that all sentences will consist only of the word sustainable. And then shortly thereafter, anyway, this is not to make fun of development economists, but just to raise in closing the traps that we face when we can't use the language of social justice, of equity, of believing that all people on this earth have equal merit. Thank you very much, and I look forward to discussion.